So good afternoon and welcome to today's HUE webinar. And today's webinar is highlighting wildfire and health research efforts. My name is Aubrey Miller. I'm the Senior Medical Advisor at the National Institute of Environmental Health Sciences, and I'm also the co-chair of the NIH Health and Extreme Weather Program. All right. So I would now like to introduce today's speakers, Drs. Ruben Juarez, Alika Mauneka, and Lilian Liu. Dr. Juarez is the HMSA Distinguished Endowed Professor at the University of Hawaiʻi Economic Research Organization and the Department of Economics at the University of Hawaiʻi at Manoa. He combines microeconomics, network economics, and behavioral economics with public health to address critical issues in underserved communities in Hawaii. Dr. Juarez is a director and co-founder of the Maui Wildfire Exposure Study, also known as Maui West. This project is the most comprehensive health, social, and biomonitoring effort to address the short and long-term health impacts of the 2023 Maui wildfires, focusing on the physical and mental impacts of health, as well as the immense challenges faced by these affected communities. Also joining us today is Alika Mauneka, who co-leads the Maui Wildfire Exposure Study. Dr. Mauneka is a native Hawaiian-born and raised, and he is also a professor at the John A. Burns School of Medicine at the University of Hawaiʻi. In studying epigenetics for over 20 years, Dr. Mauneka has made several important contributions that have helped advance the field in his work and applies epigenomic information towards understanding the mechanistic relationships of gene-environmental interactions that underlie the development of diseases of health disparities. And lastly, but not least, we are joined by Dr. Lilian Liu from University of Washington School of Public Health. Dr. Liu recently received her PhD, congratulations, and has been working on research dedicated to designing, engineering an exposure system that can be generalized, repeated, adjustable, and easily accessed by future-controlled wildfire smoke human exposure studies. So with that, I'm going to hand it over to Ruben and Alika, and then you guys will hand it over to Lilian. All right. Thanks for joining us today, and I'm sure this is going to be a great discussion. All right, Ruben, take it away.
Hi, everyone, and thank you for the invitation, Aubrey, and the NIH's team for having us disseminate some of the work of Maui. And today, actually, I want to start just by saying that I want to use Maui not only as a story of one devastating wildfire, of course, but as a source of lessons for the nation. Our central finding is simple. A disaster does not end when the hazard ends. Its effects continue through the air that people breathe, contaminants left at homes, the housing instability, of course, the stress they carry, and the systems they must navigate to recover. The fire was local, the mechanism is national, and the capacity to understand and support recovery must become national as well, while remaining locally led and community grounded. So Maui matters nationally, not because it represents every wildfire, but because it allows to see the mechanisms of disaster recovery at unusually high resolution. More than 3,000 structures were exposed, thousands of residents were displaced, and the entire community experienced environmental, economic, social disruption at the same time. But the most important lesson is not the magnitude of the fire alone, is the interaction between the fire and the conditions that existed before the fire. So to give you an idea, Maui experienced severe housing shortage before the fire, limited healthcare capacity, geographic isolation, economic insecurity, language and trust barriers. The fires created the initial shock, and these conditions shape what happened next. And this is why counting how many acres were burned, buildings destroyed, and emergency room visits is just not enough. We must measure environmental exposure, biological consequences, access to care, and the conditions of recovery together. So the fire perimeters tell us where the flames travel, but it doesn't tell us where the harm stopped.
So Maui West was designed to capture dimensions of post-disaster health that generally do not appear in emergency room or hospital records. Beginning in January 2024, we enrolled approximately 2,000 adults and children during the first year with annual follow-up. Each visit combines 3 major components, as shown here. First, participants complete questionnaires covering their wildfire exposure, housing and food insecurity, employment, social support, health behaviors, resilience, and trust, among other things. These measures allow us to understand not only what people are exposed to, but the social conditions shaping their recovery. Second, we collect blood, urine, saliva, and other biospecimens to examine environmental toxicants and biological pathways involving inflammation and stress response. We also provide point-of-care blood test results. Third, participants receive direct health assessments, including blood pressure, metabolic measures, mental health screening, and lung function testing. At this point, participants receive a medical consultation about their screening results, referrals to care, and mental health support if they express an interest in receiving it, all at the same time of study enrollment. This integrated design is particularly important from a perspective as an epigeneticist. Environmental exposures and prolonged stress may affect biological regulation well before someone develops an obvious clinical disease or requires hospitalization. By following the same people over time, we can begin to distinguish temporary disruption from persistent or emerging health effects and identify opportunities for intervention. A major strength of Maui West is that recruitment was community-led and island-wide. Although Lahaina and Kula, as shown here, experienced the most direct structural damage, the consequences of the fires extended across Maui through smoke and ash displacement, disrupted employment, caregiving, and impacts on family members. We therefore recruited throughout Lahaina, Kula, Kihei, Kahului, Wailuku, and other communities across Maui. The cohort is also racially and ethnically diverse, with strong representation of Native Hawaiian and Pacific Islander, Filipino, Hispanic, Latino, Asian, and white residents. That diversity matters scientifically because vulnerability, exposure, access to care, and recovery conditions are not distributed equally. It also reflects how this study was built through trusted local organizations, community events, healthcare partners, and relationships established on Maui. This is not simply research conducted in the community, it's a community partnership designed to generate useful information and return value directly to participating families. The preceding findings, would you like?
Yeah, so the high-level picture of the impacts is sobering. Nearly half of participants reported worse health than before the fire. We observed substantial symptoms of depression, anxiety, and post-traumatic stress. We also found measurable reduction in lung function and elevated levels of severe toxic metals compared to national reference populations. So this is not a single disaster, right? This is a multi-system health shock involving respiratory health, mental health, environmental exposure, chronic disease, housing, food security, employment, access to care. And these outcomes are interconnected. And I really want to emphasize this interconnectedness because a person may be managing respiratory symptoms while living in temporary housing, missing work, caring for children, or struggling to reach medical services. And the complexity is exactly what conventional disaster surveillance tend to separate. Our findings show that the body can continue to carry the disaster long after the smoke and is no longer visible. So the mental health findings demonstrate why this cannot be treated solely as a burn zone problem. The highest burden was among residents with the most direct exposure, but depression, anxiety, and suicidal thoughts also increase outside the burn zones in a stepwise pattern. So this is why recruiting participants not only from the burn zone but outside is really important. So even more important for policy, much of the association between wildfire exposure and mental health operated through displacement and job disruption. In other words, the fire triggered a crisis, but social and economic instability helped sustain it. And this changes how we think about disaster mental health. It's not only a matter of providing counseling after symptoms emerge, it's also a housing issue, an employment issue, an income security issue, an access to care issue. So when recovery conditions remain unstable, the disaster continued to act as a health trigger. The second thing that I want to emphasize, and this is probably the most important conceptual finding of the presentation, is that when we compare average depression and anxiety between years 1 and year 2, the population appears relatively stable. And this sounds reassuring to some extent that it's not going up, some of the symptoms, but it is actually misleading. Underneath the stable averages, some participants improve, some remain persistently burned, and a substantial proportion became worse. Nearly 1/3 reported worsening self-rated mental health. This is what we call divided recovery. Two people can be with the same levels of distress and follow completely different trajectories depending on whether they remain stable in housing, adequate food, healthcare, employment, and social conditions. Therefore, the central scientific and policy question is not simply, did Maui improve on average? It is, who is recovering, who remains trapped, who is becoming worse, and what modifiable conditions separate those trajectories. The average can remain stable, while inequality in recovery depends some of this progress. Some of the year 2 findings help us answer that question, and this is the only reason why we're able to see this is because we have this long-term longitudinal follow-up of participants. Persistent food insecurity was identified a particular high risk of mental health trajectory, and this was associated with greater probability of depression, anxiety, worsening mental health, and suicidal ideation. Food insecurity is therefore not only a measure of economic hardship, but in the aftermath of a disaster, it can function as a clinical warning signal. Housing security was strongly protective as well, but an important distinction actually emerged. Being placed in housing is not the same as being housing secure. Recovery depends on whether housing is stable, affordable, and unlikely to be lost again. Repeated moves and continued uncertainty can perpetuate the disaster even after someone technically has a roof, and we're able to see that in the data. Social support was also protective. Participants who maintained or gained strong social support had better mental health trajectories. And these are sometimes described as social determinants surrounding healthcare. Our evidence suggests something stronger. Food security, housing security, access to care, and trusted social connections are themselves components of the health response. Housing policy is health policy, food assistance is mental health prevention, and social connection is recovery infrastructure. And again, one of the things that I want to really emphasize is that these conditions are modifiable, and that gives us an opportunity to change trajectories before distress becomes chronic disease or crisis.
So what Ruben described, more of the broader health and social consequences of the disaster, I'll shift now to one of our central biomedical questions, whether environmental contaminants associated with wildfire ash and smoke were detectable internally, and whether those mixtures were associated with health. So in this slide, shows that wildfires occurring in developed areas not simply affect vegetation. They can mobilize contaminants from buildings, vehicles, electrical equipment, household products, historical land use, and underlying soils. Environmental sampling from 100 Lahaina properties documented arsenic, lead, antimony, cobalt, and copper in the ash at concentrations exceeding their respected soil environmental action levels. That established an important environmental concern, but environmental sampling alone can't tell us what entered the human body. We therefore analyzed participant urine samples for a broad panel of metals and using highly sensitive inductively coupled plasma tandem mass spectrometry through our Columbia University core partner. The key feature of this approach is the integration of internal biomarkers with geography, clinical setting, and screenings, and participant level data. Urinary measurements reflect internal exposure from potentially multiple sources. They do not by themselves prove that particular metal came from the wildfire. However, they do allow us to ask whether patterns of exposure are consistent with the disaster context and whether those patterns are related to health. So these maps show that urinary metal concentrations were not distributed uniformly across Maui. Again, these are in participants in our cohort that we sampled throughout the island. The geographic patterns differed by metal, which is what we would expect given differences in environmental sources, background exposure, diet, occupation, and the movement of smoke and ash. Lahaina stood out for several metals, particularly arsenic, but it was not elevated for every analyte. That distinction is important. We're not claiming that residence is in one region proves a specific source of exposure. However, the regional patterning, as shown here, shows that averaging everyone together would conceal meaningful geographic differences. The spatial concordance between several internal exposure biomarkers and the areas most affected by the fires strengthens the case for continued investigation, while also reminding us to consider historical and non-fire sources carefully. So we're following this up as we speak. We next compared urinary concentrations of more than 1,600 Maui West participants with national reference data from more than 1,800 participants in the NHANES cohort. Several metals were higher in the Maui West cohort. For example, as shown here, median urinary exposure was roughly 2.5 times higher among Maui West participants compared to unexposed NHANES reference cohort. We also observed substantial differences for other metals, as you can see here. Now, this comparison provides a useful national benchmark, but it should not be interpreted as proof that the wildfire caused these differences. NHANES was collected nationally, in this case, in 2011 to 2012, and it's not a contemporaneous geographically matched control population. Diet, occupation, background, environmental conditions, and other factors may contribute to some of these differences. But the appropriate interpretation is that the differences are sufficiently large and consistent and warrant further investigation and longitudinal follow-up. And this is the first time that we've observed these results in a Hawaii population. And finally, we asked whether internal metal mixtures were associated with lung function. This is just one example. This mixture-based approach is important because people are not exposed to one contaminant at a time, especially after a disaster. So we used a weighted quantile sum regression analysis to evaluate the combined contribution of multiple metals while adjusting for sex, age, body mass index, and smoking status. The positively associated metal mixture was linked to a higher odds of 2 abnormal lung function screening results, as shown here. The odds ratio was on average 1.7 for forced vital capacity below the lower limit of normal, and 1.5 on average for forced expiratory volume in 1 second below the lower limit of normal. Again, these are 2 metrics that we take at the site during the enrollment using spirometry. Arsenic contributes to the greatest positive weight for reduced forced vital capacity, while copper, arsenic, and cadmium are prominent contributors for reduced forced respiratory volume. The negative weighted mixtures, as shown here, was not significant. So these associations, of course, are not proof of causation, but the screening results don't diagnose specific respiratory disease. However, the findings are biologically and clinically concerning because the mixture signal persisted after accounting for major covariates, including smoking. So the central message here is that measuring contaminants one at a time, we underestimate the health burden of a complex urban wildfire. These findings support continued exposure monitoring, repeated lung function testing, mechanistic research, and clinical follow-up for participants, especially with concerning results. And more broadly, Maui provides a model for why post-disaster research must combine exposure science with molecular biology, longitudinal health assessment, and trusted community engagement.
Yeah, so as a lesson, I think that Maui offers 3 lessons for fire-prone communities across the country. First, a wildfire does not end when the flames are extinguished. It can initiate years of environmental, biological, economic, and social consequences. Second, exposure alone does not determine who recovers. Housing stability, food and income security, access to care, trust, and social connections can move people towards recovery or keep them trapped in crisis. And third, the burden we can see is not always the full burden. The people facing the greatest barriers are often the least likely to appear in hospital records, insurance claims, and traditional research. Preparedness, therefore, cannot end at fire suppression, evacuation, and rebuilding. It must also include long-term health surveillance, environmental and biological monitoring, stable housing, access to care, culturally grounded outreach, and trusted community partnerships. We prepare extensively for the fire. We must also prepare for the years that follow it. And as a conclusion, this brings us to the national opportunity. No community should have to invent its recovery system from scratch after disaster strikes. A national wildfire health and recovery registry could provide shared protocols, common measures, compatible data systems, and ready-to-deploy tools that community adapt locally. It would connect environmental exposure, biology, and health, and the recovery conditions, housing, food, income, social support that shape who recovers. After the next fire, communities should not have to lose a year rebuilding surveys, protocols, data systems, funding. They should be able to activate a trusted framework and respond immediately. This is not a one-size-fits-all response. It's a national capability with local leadership. Maui shows that recovery is a trajectory and trajectories can be changed. So let us build recovery intelligence before the next fire. Mahalo nui loa. And thanks to the partners.
Okay, thank you. Lilian, welcome.
Well, thank you all very much again for inviting me to present what we've been working on in the past 2 years, focusing on really sharing more resources to respond to wildfires and wildfire smoke disaster response research. And I am here to present on behalf of all my collaborators, as well as my PhD advisors, Dr. Selena Austin and Edmund Cito, and my collaborators from the University of Washington, Christine Loftus, and from the Oregon State University, Diana Rollman. So we're going to go over some of the backgrounds, what motivated us to start this research effort, and also the methods that we've used, our findings, current resources that are available, some of the things regarding the sustainability in terms of maintaining the resources, and some future improvements where we're looking for your comments, feedback, and questions. And then we're going to wrap up. So a little bit more about the backgrounds, and I'm pretty sure that everybody now are experiencing some levels of wildfire/wildfire smoke currently. And the reason why we do wanted to contribute something to the wildfire/wildfire smoke response research is that smoke and the fire itself increases in frequency, duration, and intensity in the entire United States, as well as globally, all over the places. And wildfire and wildfire smoke are slightly different from other natural hazards is because that they are more episodic with extreme concentrations, and especially we see a lot more smoke days, as well as higher concentrations in the western states in the contiguous United States. And when people talk about collecting data related to health and exposure of wildfire and wildfire smoke, most of the health data and exposure data are from administrative records, health records, crowdsourced data, modeling results, as well as many of the questionnaire data, like Alika and Ruben mentioned, the NHANES. And the DR2 platform have already gather some of the resources that are available to support disaster research. For example, there is a protocol called Rapid Acquisition of Pre- and Post-Incident Disaster Data, or RAPID protocol, to accelerate the IRB application process. And what we've identified is that questionnaires are pretty helpful, but a standardized tool is still needed to support researchers to come up with tailored questionnaires that are unique to their study goals. And again, questionnaire, we've identified that it's pretty time consuming to design, but the quality of data related to wildfire and wildfire smoke decays transiently, which means that the data are pretty perishable and need time sensitive collection. So there was we found that there is limited tools or comprehensive framework to support this rapid and tailored questionnaire design. And an example is that in 2025, during the massive LA wildfire, a team of collaborators from all over the United States came together, and they started this LA fire health study in order to respond to the assessment needs after the 2025 LA fire. And one of the major ways that people were thinking of collecting health data was using questionnaires. So our goal was to develop a decision support framework and questionnaire libraries to capture perishable wildfire exposure and health outcome. So what we've done was to come with this cyclic approach, both chronologically as well as information-wise. So basically, we had these 4 steps, starting from identifying the needs, doing literature review, coming up with this questionnaire libraries, as well as building the framework in the end. However, one step provides information for the next step, and when we've working on the second step or the third step or the fourth step, all the information were also helping us to revise and refine our previous steps. So starting from identifying the need, we had the opportunity to join this DR2 monthly meeting back in 2024, where we've came up with structured questions, and we've distributed the questions during the presentation and did a deductive analysis of people's thoughts on whether what questionnaire was useful in terms of disaster response research for wildfire and wildfire smoke. And in addition to that, we've come up with an inductive analysis approach by analyzing the listening session transcripts from the UW Rapid Facility listening session discussing the disaster response research. And then for the second step, what we've done was to screen for eligible studies from PubMed and Web of Science, and look for studies that have used questionnaires to assess health and exposure for wildfire and wildfire smoke research. And then during the literature review, we've extracted data for the common elements of the eligible study, as well as the questionnaires that they've used in those studies. And the third step that we've done was that once we've identified the literature, we've extracted the questionnaire on health and exposure data, and using those the common topics and common themes of the questionnaires, we've conducted a secondary questionnaire search using the topics on some other online repositories, for example, Red Capture Library, the DR2 platform, as well as Design Safe. And lastly, during the questionnaire collection step, we've compiled all the questionnaires into 2 separate libraries, a wildfire health questionnaire library and a wildfire exposure questionnaire library. And lastly, based on all the findings that we've had from the literature review as well as the questionnaire design, we've analyzed the themes of the studies as well as the questionnaires, and came up with a decision tree with essential modules of the framework to build the framework into a red capture survey with branching logic. And the goal was to create a survey question based on the framework module. So when people use the survey, we'll be able to return a list of questionnaires that are tailored to their study. So what we found was that yes, there was like massive needs for rapidly deployable tool in order to respond to wildfire and wildfire smoke research in a time-sensitive manner. And the common themes that we've identified in the DR2 meeting was that the questionnaires are pretty useful to collect perishable wildfire and wildfire smoke data, and a standardized tool is really needed to support the questionnaire design. And from the inductive analysis from the listening session transcripts, we found that the emergent theme, and the very first one pops up to be the data collection speed needs to be very time sensitive. And from the literature review results, we've screened thousands of studies and come out to be 30 studies that are eligible based on our inclusion and exclusion criteria. And then the current resources that we've had, one of them is the readily usable questionnaire libraries, the health outcome libraries and the exposure libraries. And in the health questionnaire libraries, we've identified 109 health questionnaires, including mental health, respiratory health, overall health, sleep, cardiovascular health, allergy, irritation, including the eye, throat, and skin, and metabolic health. And for the exposure questionnaire libraries, we've identified 2 exposure topics. One of them is the exposure assessment areas that are things related to, for example, have you ever smelled smoke? Have you ever seen the smoke? That's the sensory perception, physical exposure and impacts, acute smoke experience, time and activity of the participants, individual location, residential location, and loss of life. And the second area for the exposure questionnaire topic was the exposure modification strategy. So we've identified the questions that are asking people, if you've experienced smoke, have you ever sought shelters or alternative places to live, change your time activity patterns, behavioral changes indoors and personal, and also have you ever used indoor air treatment technologies? And lastly, in the exposure questionnaire library, we've identified some additional resources that are not necessarily helping people to support the smoke-specific research, but are resources that are very useful to come up with questionnaire design, as well as to guide people on the study itself. A note here is that not all questionnaires are validated, and we're working to improve the libraries and the questionnaires in the libraries. And apologies for the screenshots to show the wildfire health questionnaire library and the wildfire exposure questionnaire library. They're pretty small, and they're currently compiled as Excel spreadsheets. And in addition to the questionnaire libraries, we've finally designed a decision support framework that covers the topic areas of use case screening, questionnaire topic areas, and objectives and participants to further refine the questionnaire list based on study participants and objectives. And on the figure on the top right, this is a screenshot of how the questionnaire would how the survey would look like when people are using our decision support framework to try to narrow down a list of questionnaires that are really tailored and useful to their own study. And the red cap survey that we've came up with that covers the three topic areas have 51 fields and 3 sections that really is branching through the decision tree. And for example, if a group of people are trying to study health outcomes only that are associated with a smoke or fire event, they don't necessarily need to get returned with a list of exposure questionnaire, because that's not what they're looking for. So the survey question itself has the branching logic built within it, and we've already in addition to the decision support framework as well as the questionnaire libraries, we've already shared I'd call it a beta version of the questionnaire libraries with the LA Fire Health Study in the last year. So speaking of that, we're still currently trying to maintain and update the questionnaire libraries on a biannual basis. So basically in January and in June every year. And the next step is that we'd like to support the research community, develop interactive tools to standardize and accelerate data collection to better the disaster response research, specifically related to wildfire and wildfire smoke research. And we'd hope to have an online interactive and a smart platform to incorporate all the existing libraries and the framework concept to make it more user-friendly. Because currently the survey, as well as the survey is existing as a red cap survey, and the questionnaire libraries are stored as an Excel spreadsheet. So that's the end of my presentation, and I really would like to thank DR2 and the UW Rapid Network collaborators again. And I'd like to turn it to you to welcome your thoughts and comments on how we can make all these resources available to the public. And I'll pop the mic back to Aubrey.
Thanks, Lilian, and thanks, Alika and Ruben. I'm going to invite you guys to all come back on camera here, and so we can have a discussion of the great talks that we just heard. I'm really intrigued. So a couple of things in my mind, and one thing, a huge shout out to you guys on the Maui West for not only organizing and performing this community engaged work, research and beyond that you are engaged with. But the part of Lilian's discussion really beckons the issue of how did you implement this, and what did you think about when you started to figure out what tools you were going to use in terms of surveys and questionnaires, and some of the work that took place, and how long did it take from the time that you started to be able to actually start to field the study?
Yeah, that's a great question, and I think both Alika and I have similar perspectives on this, but I'll let him respond in a second too. But it took us 6 months to be able to implement the entire project, right? One of the things that we noticed, right? Yeah, one of the things. So since the first week, of the fire, we knew that community was already asking us to come in and support. But really, one of the things that we noticed is that there were no common metrics and surveys, that type of thing that we wanted to measure, even biomarkers, that we wanted to or samples that we wanted to collect, right? So we had to get community input, feedback from a scientific advisory board that we had to put on the spot. And so it's definitely one of the things that we are seeing as we advise other fires that are happening right now in the nation. We noticed that, obviously we shared all the material that we have immediately, right? But I do think that we do need over this infrastructure of common surveys, common metrics, common samples that we need to be collecting to facilitate some of the work that they are doing in other fires. And that was my last slide, actually, one of the things I wanted to emphasize.
Yeah, it's so important and to be informed by it. And you guys collected soil, you collected a bunch of media and samples, but it takes a while to get information back from that to inform your clinical research, the biomarkers you're going to measure, and then how you continue to cycle that in. So in terms of just going back to Lilian, so now I really love the fact that you guys are thinking about giving us an approach in which you can identify the surveys that are most value, right? People are relying more and more on AI, but you're giving a structured approach to say, I'm thinking about this issue. I'm going to focus on XYZ. What survey tools may be able to help me identify and do this in a more structured and standardized way? So where's that in terms of have you been able to test it yet in terms of a situation? Because there's lots of fires right now. Is anybody starting to explore it?
Yeah, thanks, Aubrey. We've actually haven't really pushed the product to the to meet the public yet, but we've definitely shared our questionnaire libraries, the exposure ones and the health ones with the LA Fire Health Study. But it was more like I said, it was more like a preliminary test. And they found it useful. But our ultimate goal was really to build this a decision support framework with the survey, where people can it would be more user friendly. So people can just click on a bunch of questions, and then by the end of the questions, voila, you have a tailored a customized list of questionnaires that are really designed to your study. And then by doing that, it's when more and more people use it, the structures of the questionnaires and the content of the questionnaire, types of the questionnaires everybody uses will be more harmonized in a way that I think the many people are criticizing, quote unquote, criticizing that, we're trying to assess the impact from a smoke event or from a fire event, but even if it's the same event, everybody comes up with different results.
Yep.
So really we're trying to have a harmonized platform for people to use and to accelerate the impact assessment.
Yeah, the comparability, the cross comparability and generalizability is such an important issue, not only in the questions, but even in the approaches and even in the sampling collection. I'm going to turn back to the chat for a minute here, and I don't know if Alika can come on screen too. But so there was a question about food, housing, and social structures as risk factors, but what about jobs in terms of the risk factors that you went through? Security risk factors for mental health and physical health outcomes.
I think jobs are a central recovery factor for sure. Employment alone is not enough, though. So we need to know whether people, have adequate income, benefits, housing, all of that, right? Which are obviously correlated with the job, having a job, right? Our findings already show that job disruption definitely help drive depression and anxiety. But again, economic recovery means restoring both the paycheck as well as, all these other social factors like housing and things like that. So, yeah.
Yeah, and I think it's really important because a lot of studies have identified the mental health impacts, whether it's wildfires, other disasters and events. That's consistent. But the fact that you guys are starting to look at these, these deeper risk factors that are contributing to the longitudinal effects that we're seeing is really important, and I really appreciate that effort. How did you guys arrive at that, and was it based on other disasters that you had looked at?
So how did we arrive to what?
In terms of the risk factors that you were looking at, so the security risk factors for the mental health outcomes?
Yeah. So one of the nice things about the study, right, is that we really didn't know what to measure at the beginning. So we tried to make a comprehensive menu of all the social factors. And in fact, this is one of the complaints that participants had at the beginning of the study, that it was this long survey of 45 minutes or so. But we really wanted to understand what are all the social factors that are basically contributing to potentially both physical and mental health. And
Well,
with
and
this
we
menu,
knew
we're
that
able to select
other-
a few of those. Yeah.
Yeah, and we knew that from previous studies. I mean, we both study health disparities in Hawaii, and we know some of the social factors that already underlie some of the health differences between populations. So we need to know that probably would be important as this plays out in recovery, and that was definitely the case. But the other thing was we really had to be cognizant of the participants themselves, the survivors of the fires, and how they would fill out that survey, what kinds of questions to ask, and how they might trigger potential mental health issues and other effects that we were really concerned about. So while we were providing the survey, this was as early as 6 months after the disaster, and then going through the whole process of screening, we made sure to have mental health providers on the spot, as well as some of our behavioral health team there present, just in case that happened, but also to address some of the needs that were already ongoing. And it was sort of an iterative process too. So it was really the responses of the participants and the survivors, their experiences that they fed back to us, that actually also shaped additional features in the questionnaire and how we would deploy it too. So it was, we had a starting point that sort of evolved with community input.
And thinking back to the fire, and it was such a massively impactful and horrendous situation. And workers were heavily involved, of course, as well as the community. And there's some questions here that are thinking about different groups that were exposed and the longitudinal health outcomes that you guys are going to be looking for. Are there workers also involved in the study? And how are you looking at the levels of exposure between the different groups, and how are you going to think about, issues that we saw in the World Trade Center, which is these long-term respiratory effects? You saw 25% that have reduced lung function, all these types of physical things, including the long-term cancers. What's kind of the current findings and thinking for those spaces?
That's a great series of questions. We think about that a lot. So the first, for first responders, we do invite them into the study. We actually had an effort to actually tailor our approach to meet their needs, go to their spaces where they've worked during their working hours, and be aware that, they wanted a separate event compared to the general public. And so we did go to some of this, we set up pop-up sites in their spaces. So we were able to collect that information and engage with first responders that way. And then they actually are been really responsive to the follow-ups as well. So they are coming into these events as we follow them up over time. We do have a way to stratify sort of degrees of exposure. There's ways so we can link them geographically to the timing of the event. We also have self-reported sort of exposure to the degree of ash and dust and things during the immediate sort of days of the fires, and then collect that information in the aftermath. We are also adding on components to our survey when participants are returning back to the burn zone sites to recover and rebuild. So that's going to be part of it as well. And then, of course, we can stratify based off of the self-reported geographic distribution of the events to see what the spectrum of exposures look like and compare sort of the health effects within that spectrum, as well as the actual physiological exposure. So that's another thing, because we don't really have a great biomarker, if you will, of a fire-specific exposure or smoke exposure. So in lieu of that, we are trying to identify what that might look like at the transcriptomic level. So we collect blood samples from individuals with a series of, self-reported exposures, right? So spectrum, as well as, like I mentioned, with the urinary analysis of specific chemicals that are implicated in the fires. So we have that spectrum too. And then we can connect that not only to health, but also, again, to the self-reported measures, as well as the geographic distribution and the duration of it when people are recovering during the process. So we have ways of trying to disentangle the impacts of the fires and the long-term effects, but it's still challenging, right? Because there are some missing pieces of the puzzle within that, and we have to make some assumptions. But we do our best, and we do have a comparator population unexposed that we are still collecting information from, so that we can see how that looks like, not only the baseline time points and doing a cross-sectional analysis, but looking at it longitudinally as well, because of course these changes will play out over time. And we are worried, very much concerned about other comorbidities associated with some of the early screening results that we're seeing, like increased pulmonary disease, as well as heart disease and cancer incidence. Especially in our vulnerable populations. We know Native Hawaiian Pacific Islanders, for example, have a higher prevalence and earlier onset of these chronic conditions than others. So one of the main reasons why we launched the study was really to make sure we can mitigate that trajectory, because we expect that probably would be exacerbated given the degree of exposure and the types of toxins and other things that they might be exposed to. So we do have a robust bank of biospecimens that we collect over time. As well as we're monitoring, the situation every year as it unfolds with the same participants. So I think what's really essential to really kind of address your question is we need that longitudinal surveillance and that continued support of not only identifying some of the risk factors, but also trying to nudge participants into a strategy of care that could help with reducing the onset of those, comorbidities associated with exposures that we already know about. So implementing best practices at the same time. So unlike sort of traditional sort of observational hands-off sort of approach to cohort design, we are really trying to incorporate a hands-on approach, really learning what we can as close to real time as possible, informing individuals on what we can do in terms of understanding what the data might mean, and then using best practices as we go along to reduce potential long-term concerns, at the same time also observing the outcomes over time, right, as we move along this trajectory. We have to say that our cohort, although it's a pretty sizable number, more than 2,000 participants, including adults and children, and it's fairly representative of the overall population that's been affected, but there's thousands more that have been affected by the fire. So we're hoping that we can use this information to inform the general population that's been affected to help reduce, the risk for continued, poor health trajectories that we would expect to emerge.
Yeah, there's a lot of questions that I'm trying to look a little bit to try to follow them, and some of these questions are quite long. But just a couple of things, and you really hit on a piece of the importance of longitudinal follow-up, and being able to look for especially disease outcomes that take a while due to latency to develop, like cancers and other potential health outcomes. And again, that's why a lot of these studies aren't done. They're hard, they're longitudinal, and it's really important to have funding, et cetera, to continue to support them. So we're hopeful that we'll continue to see that coming forward in the days ahead. There was a question related to the differences and the thinking about children. And do you have any children that are enrolled in the populations, and how's that going?
Very small cohort of children. We have about 200 children. For the follow-up, about 100 of them came back. And I think the patterns in children are unfortunately similar to those in adults, including respiratory, mental health, recovery challenges. If your parent, is experiencing depression, anxiety, children are likely experiencing those. That's pretty much what we see. But, to be fair, our pediatric cohort is really small, and funding limitations from the state of Hawaii, basically inabilities to support an expansion to children, restricted recruitment and follow-up. But yeah, children may be especially vulnerable because they are still developing, have decades ahead of delayed effects to emerge potentially. So we cannot stop following them up, basically. And that's actually the priority for the next phase, expanding to children.
Yeah, there's some questions a little bit more, and you could probably answer these offline, but about the types of biomarkers and things that you could be following, including you're thinking about dioxins and other things that are the potential carcinogens and things. Obviously, you found what looks to be a relationship just between the mix of heavy metals and lung function, which was really interesting. So maybe it's an indicator of exposure potentially, as you're saying it, and there'll probably be some other ones that'll be very interesting to follow on. But maybe you can comment a little bit of some of the other markers of exposure and biomarkers that you're thinking of that look interesting right now as things begin to evolve, and including some of the other health endpoints, stress, inflammation, were some of the ones that you had identified as areas of particular interest.
Right. So again, we're using a sort of a broad omics approach to better understand sort of the gene pathways that might be affected and relate more to the exposure, not only to identify sort of the underlying mechanisms of the pathology that we might see with our health screenings and sort of the some of the endpoints that we're going to be monitoring for over time, but also to identify these biomarkers of exposure as well. So part of that, actually, one of the things as an epigeneticist I'm so interested in understanding better is the role of epigenetics and their potential utility in capturing some degrees of environmental exposures, especially related to the wildfires, and how that might actually be contributing to some of the transcriptional dysregulation that might offset inflammation and inflammatory responses that can contribute to the pathology of disease conditions that might underlie some of the exposures that we're seeing. So what one specific sort of biomarker that we're really interested in understanding better is epigenetic aging. So using DNA methylation data as a way to quantify or calculate sort of the biological aging of an individual. We expect that potentially trauma, stress, these types of exposures might already trigger exacerbated or earlier accelerated biological aging. We already know that in certain populations in Hawaii, there are certain populations, like, for example, our previous work showed that Native Hawaiian Pacific Islanders have a higher degree already of accelerated aging, higher frequency of accelerated aging using DNA methylation data compared to other populations in the state. We related that to some social factors, but we suspect that potentially this type of exposure might relate to those social factors that then can also contribute to accelerated aging in this subpopulation of affected individuals. So we're trying to understand how that might be potentially a mediator of some of the interactions that we see with the transcriptomic data that shows that maybe it's connected to a higher degree of inflammation and other stress response pathways that then can, over time, if really not addressed, can lead to some of the development of the chronic conditions that we are starting to see from our screening results. So that's something that we're looking into right now. And I think the value of our biorepository is that we can start to ask those questions and then combine them with these omic approaches to kind of get a better understanding instead of a targeted approach where, it's more hypothesis driven, but because we really want, there's a lot of unknowns here, we'd like to explore a larger sample size and, increase the opportunity for us to identify relevant pathways that then we can later focus in on.
It'll be so important for us to do additional studies at other wildfires and start to do some of this comparative analysis and see what we're seeing across populations as well. There's been some questions here that are touching on the relationship between healthcare and additional kind of public health remediation efforts, mitigation efforts, etc. But as you begin to either identify people that are at risk, obviously mental health being a large one, but other particular kinds of health outcomes, how is that relationship with the current healthcare infrastructure? How did you actually develop that? where's it going? And as you identify additional things, do you have a system in place for being able to refer people accordingly, etc.?
Yeah, so we actually have so one of the things that obviously Maui had before the fire was that it's a rural area where like health infrastructure was an issue even before the fire. So when the fire came, basically it was a shock. And just to give you an idea, the specialized services in the island of Maui are very difficult to access. So when we arrived, there was a half-time pulmonologist who retired actually during the fire, right after the fire. And then right now there is one pulmonologist, but that's actually one of the priorities of the state of Hawaii. We definitely are trying to like link as many participants to services as we can, right? I mean, this is one of the priority. It's always a challenge. Anyone who wants to volunteer, in the nation to help us build that infrastructure, obviously we welcome that. But yeah, so Alika and I think the next phase, is really to build and use the community partnerships and resources available in Maui to bring participants into services. And through this Hoala initiative, and I'll let Alika present that in 1 minute.
Yeah, we have we think that some of the findings can inform a structured approach to filling some gaps in the current healthcare system in rural areas in Maui and also to the state. We call it Hoala, which is a Hawaiian word for to reawaken, to wake up. It stands for Health Outreach Aina-Based Life Course Alliance, and the idea is to integrate information from environment, about environmental hazards, contextualize that information with individual innate traits, and also inform individuals about potential hazards in the environment to mitigate their contact with it, as well as screen and increase the capacity actually for early disease detection through these health screening services that then can be linked to clinical services in the networks that we have. And so we're working closely with our health providers and our healthcare services here on Maui, like Kaiser Permanente, for example, not only to implement some of the insurance coverage that was lost in the wake of the fires for certain members, but also to increase the capacity for their care. Because we think that, what ultimately I think can be defined, and maybe this is something that we can do across the country, is identify the wildfire exposure syndrome, because there's going to be a core cluster of certain very commonalities. Of course, it's the disease outcomes, and sort of there are going to be some slight variance depending on the initial experiences and what specific hazards might contribute to those conditions. But I think there's going to be a core sort of set of commonalities across the system. So it would be a syndrome. And I think what we really are challenged by is informing providers how to address the multiple complicated needs of people being exposed to fires, not only the physical health needs and mental health needs, but also the social needs are wrapped around all of that. So this whole ALA infrastructure is designed to integrate that information, that kind of information, to help support the current healthcare system. And hopefully what the end result could look like if you had this in place is the reduced onset, right? Reduced onset of these comorbidities associated with exposures. And so there's a reduced need for specialty care, at the same time inform policy to mitigate sort of some of the environmental factors, social factors that might be contributing to those things in the first place. So if we had this sort of integrated infrastructure with that intent, I think we would really be better off in terms of the next disaster and build resilience against the next one, because we'd be ready to basically improve the health and well-being of the community in the first place. And I think by doing that, we can then really shape the recovery process at the same time. And so that's something we're really advocating for support. And I think the data that we're collecting through Maui West is informing that.
Yes, unfortunately, we are at time, right at time. And I wanted to thank you guys. I mean, this was an incredibly invaluable discussion, and there's so much more we would love to go deeply into, and we'll look forward to additional discussions in the days ahead. And not only the importance of doing this type of work in response to a situation like these wildfires, which are continuing to occur not only in the U.S., but right now in Europe, which is having its highest level, but the ability to develop the questionnaires and have them readily available, having the types of tools, and having the learnings from the type of work that you guys are doing. Thank you for joining us today. I really appreciate it. I want to thank everybody for participating. And again, we will have this recording made available, and we'll look forward to continued discussions in this realm. Appreciate everybody and have a wonderful day.